Hello, this is Heidi Silver at Vanderbilt University Medical Center in Nashville, Tennessee, where I am a research professor and director of the Diet, Body Composition, and Human Metabolism Core. I'm going to take some time to speak to you about the relationship between the infiltration of fat into skeletal muscle in today's adult who has HIV and how it is associated with the development of glucose intolerance and type 2 diabetes in HIV. I'm limited to 15 minutes of speaking, so I will pause on slides to give you more time with each slide. I have no disclosures or conflicts of interest. We have received funding from an award from the National Institutes of Health and an award from the Department of Veterans Affairs to conduct research on ectopic fat in HIV and its relationship to glucose tolerance, insulin resistance, and type 2 diabetes. Today, there are over 38 million people living with HIV around the world. And people with HIV are living longer due to the success of antiretroviral treatments. What's happening is that antiretroviral therapy, ART, is being initiated or started in HIV disease earlier, and individuals are taking these medications for longer periods of time, leading to greater life expectancy. Unfortunately, what's also occurring is the development of overweight and obesity in people with HIV, where we used to see many years ago a great prevalence of weight loss and underweight in HIV. We now see a much greater prevalence of overweight and obesity. And with this increase in body weight on ART therapy, we see a greater accumulation of fat in the abdominal depot, or what is known as visceral adipose tissue. As a consequence of the intersection of HIV and obesity and the development of visceral fat, we see impairments in the ability to use lipid or fat for energy and increase storage of fat as opposed to using it as a fuel, and significant effects on both the efficiency of using fat and the efficiency in which glucose is utilized in cells. And so as a result, we see at an earlier age in the individual with both HIV and obesity, impairments in lipid and impairments in glucose that result in hyperglycemia, insulin resistance, and hyperinsulinemia. Here you can see that obesity is widely prevalent across the globe in HIV, and I've shared, based on continent, the current prevalence. Now, this study showed the increase in fat mass compared to the increase in lean mass when body mass increases in individuals with HIV on antiretroviral treatment. And you can see that the percent increase in fat mass, a 13% change, is far greater than the percent increase in lean or muscle mass. Indeed, for every 5 pounds of weight gained, there's an increased risk of type 2 diabetes by 14% in the HIV positive individual. So this weight gain is really creating a state of much higher risk for type 2 diabetes and also for cardiovascular disease in the treated HIV individual. Here we've compared 97 of our patients with HIV and looked at the ratio of visceral to subcutaneous fat. And you can see that as the ratio of visceral to subcutaneous fat increases, there's a greater likelihood of going from being insulin sensitive to pre-diabetic to full-blown type 2 diabetes. And there is a direct linear relationship between the increase in the ratio of visceral to subcutaneous fat with the presence of hyperinsulinemia in the HIV positive adult. And this is data from 97 of our patients at Vanderbilt University Hospital and the Nashville VA, Veterans Administration. So what's happening overall is expanding visceral adipose tissue because a limited capacity of the subcutaneous compartment to expand in the state of HIV and store fat where it's supposed to be in the subcutaneous compartment. And so with this, we have not only an expanding visceral compartment where there's great infiltration of fat, but also the release of free fatty acids into the circulation, both the systemic and portal circulation, leading to the development of fatty liver and fatty muscle. And both fatty liver and fatty muscle promoting a state of insulin resistance. When we look at all our individuals who have both HIV and obesity, we see that not all of these individuals are alike. Some develop fatty liver disease, some develop type 2 diabetes, some develop sarcopenia or atrophy of their muscle when there is this infiltration of lipid in the muscle. And so you see a relationship between the visceral adipose tissue expansion and the expansion of fat into the skeletal muscle, accumulating more in individuals with HIV compared to those without HIV. Now, to be clear, this is not just occurring in older adults with HIV, but we're seeing this in middle-aged adults. And here on the left, you have an image from MRI that shows this infiltration of fat in the skeletal muscle, myosteatosis, and on the right, how much this interferes with the synthesis of muscle and the worsening of glucose intolerance and hyperinsulinemia, leading to the development of prediabetes and full-blown type 2 diabetes. Here is our own data presenting this relationship between the worsening of infiltration of fat in the skeletal muscle and the worsening of glucose tolerance when we compare HIV positive versus HIV negative persons. Here we compare this infiltration of fat in the skeletal muscle. So you see fat in green and infiltrating into the red, which is the skeletal muscle. And you see how much worse it is as the individual who has HIV compared to the individual who does not have HIV, and how much expansion there is of the visceral fat, the yellow, within the abdominal compartment, along with this infiltration of fat into the skeletal muscle. Now, what we've noticed is that this infiltration of fat in the skeletal muscle in HIV-positive adults is associated with a change in amino acids that affect the ability of the mitochondria to use fat as a fuel, to oxidize fat, and the flexibility of the mitochondria in the process of metabolism. And so you see here, there are a different profile of the acylcarnitines with the HIV obese individual than we would see in the obese HIV negative or the normal weight HIV positive individual. And the actual content or density of the mitochondria is impaired in skeletal muscle in the individual who goes on and develops type 2 diabetes compared to those without type 2 diabetes. Of course, this is not just occurring in the abdominal depot, but the amount of skeletal muscle in the abdominal is highly correlated with whole body. And so we see this amount of fat infiltrating in other muscle groups and is much greater in those who have both HIV and obesity, or HIV, obesity, and diabetes than we see when we compare them to others. And there is a direct relationship between this higher lipid content of the skeletal muscle that we're seeing developing and the mitochondrial function being even worse in those who then go on to develop type 2 diabetes. And so here in this slide, you see recovery of phosphate creatinine activity in the mitochondria takes longer when there is more lipid in the muscle. There are other effects on the whole body with regard to this decline in skeletal muscle, and we see this in the effect on energy balance. And so here we see in the HIV positive individual, based on rigorous doubly labeled water studies, a lowering of resting energy expenditure, which contributes to the development of obesity in the HIV positive individual. What we can do about this is a bit impaired on the fact that there have not been many diet interventions for obesity in the state of HIV in the current type of treatment that is being received by HIV positive individuals. But in this study, we see a randomized controlled trial of behavioral weight loss compared to education over a 12-week period in obese individuals with HIV. And we can see that there is a significantly greater weight loss with behavioral weight loss intervention. We have concern, however, that when we prescribe only a calorie deficit for obesity in the HIV positive person, that we have a much greater loss of muscle mass in proportion to fat mass loss. And so we have to consider what we can do in our diet interventions, not only to reduce calorie intake, but how do we maintain muscle mass while weight loss is occurring for obesity? And just providing resistance exercise to increase muscle mass may not be enough in the HIV positive individual. So here's a slide summarizing what we need to assess and what interventions we can do.